Welcome back. In the chapter of health programs in India, in today's session, we will discuss about the National AIDS Control Program. Before entering into the National AIDS Control Program, let us see about AIDS. AIDS is the acquired immunodeficiency syndrome. It is caused by HIV virus, that is human immunodeficiency virus. So we see that AIDS, acquired immunodeficiency syndrome, AIDS, is caused by HIV virus. AIDS is caused by HIV virus, human immunodeficiency virus, which belongs to the family Retroviridae. The disease is characterized by profound immunosuppression. It leads to opportunistic infections, secondary neoplasms, and neurological manifestations. So, we see that the disease, once the person is contracted with the disease, it leads to immunosuppression. The immunity of the person gets suppressed because it is immunodeficiency virus. It brings down the immunity of the person. Once the immunity is lowered, it leads to opportunistic infections. This leads to secondary infections, neoplasms, neurological manifestations. National AIDS Control Program was launched in the year 1987 in India. The Ministry of Health and Family Welfare has set up the National AIDS Control Organization NACO as a separate wing to implement and monitor the program. So we see that the Ministry of Health and Family Welfare, they set up a separate wing or a separate, organization for the control of AIDS. National AIDS Control Organization was set up by the Ministry of Health and Family Welfare to monitor and implement the program. What program? The National AIDS Control Program. What is the aim of this program? Aim is to prevent further transmission of HIV. Now, what is our aim? We need to prevent the further transmissions of HIV need to be prevented. To decrease the morbidity. What is morbidity? Morbidity is a disease. We need to prevent the disease as well as the mortality, death occurring due to HIV. Also, thirdly, minimize the socio-economic impact which is resulting from the HIV infection. I hope the aims are clear. Moving on to the milestones of the program, the first case of HIV was detected in the year 1986. So we know the program was launched in the year 1987. So the first case was detected in the year 1986. The AIDS Task Force was set up by ICMR. The National AIDS Committee was established under the Ministry of Health. So, the Ministry of Family, just like we saw, the Ministry of Health and Family Welfare, they set up the National AIDS Committee as well. In 1990, the medium term plan was launched for 4 states and 4 metros. In 1992, the National AIDS Control Program 1 began to slow down the spread of HIV infection. Once in 1986, the first case was contracted. Later, by the 1992, they slowed down the spread of infection. The National AIDS Control Board was constituted. Further, the NACO was set up. So we saw NACO, the National AIDS Control Organization, was set up in the year 1992. In 1999, the NACP, which is nothing but National AIDS Control Program 2, begins. It is focusing on the behavior change, increasing the decentralization and NGO involvement. The state aid control societies were also established in the year 1999. Following, in 2002, National AIDS Control Policy was adopted and National Blood Policy adopted in the year 2002. In 2004, antiretroviral treatment was initiated. In 2006, National Council on AIDS constituted under the chairmanship of the Prime Minister. So the National Council on AIDS under the chairmanship of Prime Minister. In 2007, NACP3 was launched for a period of 5 years from 2007 to 2012. In 2012, NACP4 was launched for 5 years again from 2012 to 2017. So 7 to 12, 12 to 17. 5-year plans. Following, we have the NACP4 from 2012 to 2017. It was launched, and the primary goal is to halt and reverse the epidemic in India for the next 5 years. In 2017, the National Strategic Plan for HIV or AIDS and STIs was initiated, and it was a 5-year strategic plan again from 2017 to 2024. This is from the latest edition, we got this information. Okay, latest edition of Park's textbook. So now guys, in the milestones, what you have to remember is from your exam point of view. This is like general you got to know. From your exam point of view, the strategies are very important, and in the milestones, when was the program launched? You have to remember when the program was launched. So we know in 1987. So you have to write down the National AIDS Control Program was launched in the year 1987. And the first case was contracted in the year 1986. Easy to remember. 1987 the program was launched. 86 first case was detected. And you have to write about these four. 92 NACP 1, 99 NACP 2. Okay, 92, 99. NACP 1 begins, it slowed down the spread of HIV infection, whereas NACP 2 was focusing on the behavior change and increasing the decentralization and NGOs involvement. Following, NACP 3 was launched as a 5-year plan, and NACP 4 next 5-year plan. You have to remember 2007, add 5, 12. Okay, again 5. So from 12 to 17. Okay, this is how you have to write down the important milestones which you can remember well. Followed again NACP 4, the 5-year plan. That's all. So this was about the milestones. Lastly, you can write the National Strategic Plan for HIV or AIDS was started, and again it is from 2017 to 2014. So 2024. So let us try to recall the milestones what we studied. First thing, what will you write? In 1987, the program was launched. In 1986, the first case was detected, and then we will start with 92 and 99. In 1992 and 1999. In 1992, the National AIDS Control Program first phase was started. In the first phase, we see they worked on the slowing down of the spread of HIV infection. Whereas NACP 2 in the year 1999, it was focusing on the behavior change and NGOs involvement, increasing the decentralizations. Then we will go to NACP 3. NACP 3 2007. Again from here plus 5 years. 2007 to 2012. From 2012 to 2017. Okay. So this was about NACP 3 and NACP 4. Clear. So the milestones we know what to write. Moving further, the high-risk groups are the female sex workers. The high-risk groups, female sex workers, men who have sex with men. So these are the high-risk groups for HIV infection or AIDS. So who are the high-risk group people? The female sex workers, men who have sex with the men, transgenders, injecting drug users. So IDU users, injecting drug users. Fine. And then the vulnerable population, those who are vulnerable to the infection are women who are having casual sex partners and spouses of the high risk groups. Okay, the spouses of these high risk groups, female sex worker, her spouse is prone to have HIV, and then the transgenders, and then men who have sex with men, and this thing you remember, the female sex worker, spouses of having high risk group. Then, moving further, we have the bridge population or the close proximity to the high risk group. These are the bridge population. They have very close proximity to the high risk groups. They are the migrants, they migrate. And then the truck drivers, the truckers, clients of the sex workers. Okay, the clients of the sex workers are also close to contracting the infection. So, with that in the mind, so the ones who are prone to it, the high risk groups, and the bridging population and vulnerable population, having those on mind, let us see about what the program is dealing with. The package of services which are provided under the National AIDS Control Program 4 includes the prevention services, care, support, and treatment. First is prevention. Prevention service. Prevent the disease. In the second place, in case the disease has occurred, give the proper care, support, and treatment. First, prompt treatment. Care, support is very important. Now, let's see what is included in the prevention services. Prevention services targeted interventions for high risk groups. We need to perform interventions in the high risk groups like the female sex workers, men who have sex with men, transgenders, hijras, injecting drug users, and the bridge population like the truckers and migrants. What we saw, these are the targeted people, high risk groups. In them, we need to perform the interventions, targeted interventions for the high risk groups. Needle syringe exchange program and opioid substitution therapy for intravenous drug users. For those who are intravenous drug users, we need to give this opioid substitution therapy. Prevention interventions for the migrant population at source, transit, and destination. Those who are migrated, and those who are during the process of migration, and those who have reached to the other place, their destination. In such a migrant population, we need to bring in the prevention interventions. Link workers. The link worker scheme for the high risk groups and vulnerable population in rural areas. Continuing, we have the blood safety. The blood to be transfused should be HIV free. HIV counseling and testing services. Prevention of parent to child transmission. In the next slide, in the upcoming slides, we will discuss in detail how to prevent the parent to child transmission. Condom promotion. Condom protects the people from contracting the sexually transmitted diseases, HIV, AIDS, also the pelvic inflammatory diseases. So condom promotion has to be done. Information, education, communication, and behavior change communication. IEC and behavior change communication has to be done. Following the social mobilization, youth interventions, and adolescents education program. Social mobilization, the youth intervention, okay, and adolescents education. We need to give education to the adolescents, else they will be prone to all such things. Workplace intervention as well. Moving on to the country's scenario. The high prevalence, so based on the sentinel surveillance, the country's scenario, that is the classification of the states, based on the sentinel surveillance data, the HIV prevalence in the adult population, it has been broadly classified in these three groups of states or union territories in the country. The group 1 is high prevalence states. It includes the states of Maharashtra, Tamil Nadu, Andhra Pradesh, Karnataka, Manipur, Nagaland, where the HIV infection has crossed 5% in high risk group and it is more than 1% in the antenatal women. So here it is more than 5% in high risk groups, and less than more than 1% in antenatal group. More than okay, in antenatal group, antenatal care units. And then we see the moderate prevalence, that is the second group. In the second group, that is group 2, which is the moderate prevalence states, those include the states of Gujarat, Goa, Puducherry, where the HIV infection has crossed more than 5% in the high risk group, but the infection in the antenatal women is less than 1%. So we see that it is more than 5%, more than 5, more than 1, more than 5, but it is less than 1%. Lastly, the low prevalence group, the third group. It includes the remaining states where the HIV infection is less than 5% in high risk group and less than 1% in the antenatal women. Simple, guys. Let us just summarize. Yeah, high risk, the first group was high prevalence group, not high risk. High, okay, yeah. High prevalence group, moderate prevalence group, low prevalence group. Yeah. So more than 5% in high risk group, more than 1% in antenatal women. More than 5% in high risk group, less than 1% in antenatal women. Less than 5% in high risk group, less than 1% in antenatal women. Fine. We are done with the categories, classification. Moving on to the HIV surveillance. The different types of surveillance activities are carried out in the country in order to detect the spread of the disease and to make the appropriate strategies for the prevention and control. Therefore, the surveillance types include the HIV sentinel surveillance, HIV sero surveillance, AIDS case surveillance, STD surveillance, behavior surveillance, integration with the surveillance of other diseases like TB. So, what are the different surveillance we saw? HIV sentinel, HIV sero, AIDS case, STD, okay? AIDS case surveillance, STD surveillance, behavior, integration of the surveillance with other diseases. Okay. So the first four we know: HIV sentinel, HIV sero, AIDS case, STD surveillance. Clear? The surveillance types we studied. Moving further, we have what is a sentinel surveillance? Sentinel surveillance, it is done to detect the hidden cases in the community. The main objective of this setting up of a sentinel surveillance is to detect the hidden cases in the community. Instead of attempting to gather the surveillance data from all the healthcare workers, now we have to go to the ASHA workers, Anganwadi workers. Instead of going to these, data from, instead of collecting the data from healthcare workers, a sentinel surveillance system will select, either randomly or intentionally, it will select a small group of health workers from whom they can gather the data. Instead of going to each unit, they will allot few people who will help us to gather all the data. These health workers then receive a greater attention from the health authorities than would be possible with universal surveillance. It is more detailed, more accurate data is obtained from this. So we know very well that when we do this, instead of going to each PHC, CHC, hospitals and medical colleges and collecting the data, if we set up a sentinel surveillance which will help us to collect all the data and give the information, this is much better. It will give us a more detailed, more accurate data. It is obtained from this sentinel surveillance. HIV sentinel surveillance. So now we are discussing about HIV sentinel surveillance. We know what is sentinel surveillance now. This HIV sentinel surveillance was started in the year 1994 with 55 sentinel sites. What are the objectives of this HIV surveillance? The types of surveillances we studied, the objectives include to determine the level of HIV infection, to understand the trends of HIV epidemic. So first thing they need to determine the level of HIV infection. So we studied the categories. So first they need to know if it is high prevalence or moderate prevalence, the level of the HIV infection. To understand the trends of HIV epidemic, how is the trend of the epidemic has to be found out. To understand the geographical spread of HIV infection and emerging pockets. So they need to identify those geographical areas where the HIV epidemic has occurred and how it can spread to the nearby areas. To provide the information for prioritization of the resources, they need to provide the information so that they can prioritize the program resources, they can perform the evaluation of the program impact. To estimate the HIV prevalence and HIV burden in the country. So we know to estimate HIV old cases, how many cases were present, how many cases, and then what was the burden of the HIV in the country. Objectives best achieved. These objectives can be best achieved by the annual cross-sectional survey of the risk group. We need to perform the cross-sectional survey of the risk group. So I hope the objectives are clear. First, we determine the level of HIV infection, the trends of HIV epidemic. We understand the spread of HIV, that is the geographical spread of HIV infection. We provide information for prioritization of resources, information. Last, we estimate the prevalence and the burden in the country due to HIV. Counseling and HIV testing services. It includes the following components: Integrated Counseling and Testing Centers, ICTC, Integrated Counseling and Testing Centers, Prevention of Parent to Child Transmission of HIV, which is PPTCP, HIV or tuberculosis collaborative activities. So we are discussing about the counseling and HIV test services, wherein we perform the counseling and testing centers and we prevent the parent to child transmission of HIV and collaborative services. Moving to the types of ICTC. What is ICTC? Integrated counseling, integrated counseling and testing center. What are the types of this integrated counseling and testing centers? They are fixed facility integrated counseling and testing centers. The standalone or a facility, they are fixed, okay? So the client load is high. They are located in MCs, DH, SDH, CHC. And then with separate staff, it has a separate staff. In cases of facility integrated counseling, we see that they are setting up below the block level. Here it is at the level of community. Here it is below the block level. It is at the district level, the standalone facility. Whereas the facility integrated counseling and testing centers, they are below the block level at 24/7 PHC. Their existing staff is trained. The mobile ICTC, it includes a van with a room to conduct the examination and counseling. Mobile, it can move. This clinic can, facility can move about. So it is mobile integrated counseling and testing center, wherein there will be a van with a room to conduct the examination and counseling and testing services. It's set up as a temporary clinic. Okay. So what is the difference we saw? Here the client load will be quite high. They have a separate staff. It is at the district level, whereas this is at the PHC, below district level, and village level. And here the staff is trained, the existing staff, they don't have any separate staff for this. And mobile ICTC, which is a van which is having a room. This is a van which is having a room where the counseling and testing is performed. Okay, it is a temporary clinic. Prevention of parent to child transmission. As I said earlier, we'll be discussing about it. It started in the country in the year 2002 with a single dose of Navirapin. So we see single dose Navirapin, SDNVP. Prophylaxis to HIV positive pregnant women. So any pregnant women who is HIV positive will be provided with one dose, a single dose of Navirapin, okay, during labor, and also for her newborn child immediately after the birth. So also after the birth, the baby also gets single dose Navirapin, okay, Navirapin. Fine. What is the aim of this prophylaxis? To offer the HIV testing to every pregnant woman. Universal coverage has to be done, and eliminate the transmission of HIV from mother to child. So the prevention of parent to child, PPTCP, is concerned with what is the aim of this thing is to eliminate the transmission of HIV from mom to child, and to offer the testing to every pregnant woman. That is universal coverage. Every pregnant woman needs to be checked. So this is the program, the prevention of parent to child transmission of HIV AIDS program. It was started in the country in the year 2002. So this program was started in the country 2002, and they are giving a single dose of Navirapin to the HIV positive pregnant women. Aim was to offer HIV testing to every pregnant woman, universal coverage, and prevent the transmission of the HIV from the mother to the baby. India has also transitioned from the single dose Navirapin strategy to that of a multi drug ARV prophylaxis. So we see that further now the India has also advanced, where they are not giving just a single dose, but now they are giving a multi drug ARV prophylaxis in September 2012 to HIV positive pregnant women. So we see that before they used to give only single dose Navirapin, but now it is multi-drug ARV is given to the HIV positive pregnant women. The activities which are aimed to reduce the HIV or TB mortality includes the prevention, early detection of TB and HIV, prompt treatment. So first thing, prevent it. In the first place, prevent. Then early detection. In case the disease has occurred in the person, early detection of the TB or HIV. Once the case is detected, it is diagnosed, confirmed, then give the prompt treatment of the TB or HIV, followed by the management of the TB or HIV cases. In the prevention, isoniazid prevention treatment. So we give this isoniazid prevention treatment. Airborne infection control. Awareness generation. We need to bring in the awareness, providing the information, education, communication, behavior change communication in the people, creating awareness in the generation. Early detection of TB, 100% coverage of PITC. Okay, in TB patients, that is nothing but the provider initiated HIV testing and counseling. We are providing this 100% coverage in the provider initiated HIV testing and counseling in TB patients. And provider initiated TB testing and counseling services, it is presumptive for the TB cases. rapid diagnostic detection of TB and DRTB in the PLHIV. So, PLHIV, we are detecting the cases, diagnosis is done. ICF activities at all HIV settings. So, we need to have this intensified case finding at all the HIV settings. The case finding should be intensified case finding. Now, the prompt treatment of TB and HIV, early initiation of this multi-drug ART, and prompt initiation of the TB treatment, obviously. In the management, we are TB and HIV patients on the PI based ARV. We are performing this PI based ARV, multi-drugging. TB or HIV in the children, and the specialized cases these are TB, HIV in pregnant women, drug resistant TB or HIV. So guys, the four important things is prevention, early detection, prompt treatment and management. Okay, these are the activities which are done to reduce the HIV or TB mortality. First is prevention, second detection, early detection, third prompt treatment, lastly management of the special cases. Moving to the care, support and treatment. It is aimed to provide the comprehensive service to people who are living with HIV. For the people who are living with HIV, we are giving them a prompt comprehensive services. With respect to free antiretroviral therapy, so we are giving a free ART, antiretroviral therapy. The psychosocial support and prevention and treatment of opportunistic infections, which are including the TB, facilitating the home based care and impact mitigation. So, impact mitigation is to remove the suffering. Whatever the suffering a person has because of HIV needs to be removed. So, these are the aims of care, support, and treatment. Under the care, support, and treatment, the care, support and treatment component, it is one of the component of National AIDS Control Program. So far we saw what were the components. We saw the first component was the prevention of parent to child transmission. The first thing we saw was from here it started. The components are counseling and HIV testing services, integrated counseling and testing services, where we studied the types. Then the second component we saw the prevention of parent to child transmission, and then the activities we saw, followed by the care, support and treatment, which is a component of National AIDS Control Program, whose aim was to provide the comprehensive services to the people who are living with HIV. Okay, so that we can improve their survival, we can improve the quality of life of the people who are suffering with HIV, providing a psychological support to them, psychosocial support, prevention, treatment of the further secondary infections, including the TB, and facilitating the home based care for these people and impacting the mitigation, followed by the services which are provided under the National AIDS Control Program is the first line ART. So we saw that antiretroviral therapy. The antiretroviral therapy is provided free of cost to the eligible PLHIV through ART centers. We are giving this free of cost first line ART, that is antiretroviral therapy, to these people. And we also have the targeted intervention. We studied this earlier, the targeted groups like the female sex workers, transgenders, and the kids who are born to these people. We are performing the targeted interventions in them. Linked worker scheme, blood transfusion services, and then we have STD control program. So let us see a little about all of this. First thing, adult and pediatric ART, wherein we are providing this the National Pediatrics HIV/AIDS Initiative, where we are providing the first line therapy very efficaciously, and we are promoting the children to show the evidence of the failure. Okay, even though certain children show the evidences of the failure, we still are having a very efficacious therapy for the pediatric group. So we see that in early infant diagnosis is done, the follow up and monitoring is performed in them. We manage the opportunistic infections which are coming, and the opportunistic infections, they have to be screened, and management is done of the various opportunistic infections, which is a very important part of this comprehensive HIV care. Okay, and then the targeted intervention. In the targeted intervention, it is usually done for the high risk group. The main objective of this targeted intervention is to improve the health seeking behavior in the high risk groups, and we have to reduce the risk of these people acquiring the sexually transmitted infections or HIV infections, like these female sex workers, men who have sex with men, transgenders, hijras, and injecting drug users, the abridged populations like the migrants, long distance truck drivers. So in these targeted interventions, we need to give them the information, then skills, which so that they can prevent the HIV transmission. Next, the link worker scheme. The link worker scheme, which is a community based outbreak strategy. It is community based. Link worker, it is a community based strategy where the HIV prevention and care needs of the high risk group and rural population is taken care of. The main strategy, it is addressing to the high risk groups and vulnerable population. The main objective of this link worker scheme is reaching out to these groups and giving them the information and knowledge how they can prevent and reduce the risk of HIV and STI. Like we can promotion of the condoms can be done, providing them the referral services, and counseling, testing, treatment can be done. Okay, in the link workers, followed by the blood transfusion service. Now we move to the next point, that is blood transfusion service. What does the blood transfusion service include? So initially they used to tell it blood safety service, but now they have renamed into the blood transfusion service. Our main horizon is to include the transfusion which is transmitting the infections. So that any blood transfusion which is transmitting the HIV infection has to be taken care of. The quality management systems, where the blood transfusion services, it is a very integral part of the healthcare system, and we have to have a good access to the safe blood. Okay, and we need to test every unit of the blood if it is having HIV or hepatitis B, C, malaria, syphilis. So we need to first check for the blood and then perform the transfusion. And also we need to ensure the safe collection, the storage, distribution of the blood and blood products have to be done in the very carefully in the blood banks. Okay, next, STD control program, and we also have this condom promotion which is done. So the STD control program is nothing but the condom promotion strategy, where the program with this program we provide the free distribution of the condoms, and social marketing channels, non-traditional outlets also encourage the female condoms, etc. How can we do this? By effective communication strategy. Then we have including this we have, so you can consider this as a separate thing. Okay, blood transfusion services, then we have condom promotion. Yeah, 4, you can consider this as the sixth point. Fifth, condom promotion. Under condom promotion we saw promotion is done. Next, STD control program, where it is linked to the control of the behavior, where we are controlling the behavior which is resulting in the transmission of STD and HIV. So we know we need to control the behavior which is resulting in the transmission. Hence, we need to perform the early diagnosis, treatment of the STD, as the STD is one of the major, problem, and we need to control the spread of this HIV infection through syndromatic approach. We need to check the specific symptoms and signs and detect the cases, perform the diagnosis, and give the treatment. ART. So ART, we saw it's a first line art which is given to. So we will just see, quickly revise the points what we studied. In the first line ART, it is given to the new cases through the ART centers, and we also have this alternate first line ART, where there is the patient with intolerance to the first line ART will have a center of excellence and art plus centers. So these patients who are like the first line of treatment, they are resistant, so they have the center of excellence and art plus centers, ART plus centers. The second line ART, it is giving the treatment, it is given to treatment failure of first line. In case the first line treatment is failed, then we have the second line ART. It is an alternative of first line ART, and through COF and ART plus centers, again COE, that is center of excellence and art plus centers. Targeted intervention, what did we see in this? The objective is to improve the health seeking behavior of the high risk group, reduce the transmission of acquiring the STDs and HIV infections in the high risk group. We need to target the high risk group. We need to reduce the risk of acquiring sexually transmitted infections. We need to reduce the risk of transmitting HIV. Then the high risk groups are those who are the female sex workers, men who have sex with men, transgenders, hijras, injecting drug users, bridge populations including high risk behavior migrants, and long distance truckers. So all of this we have studied. Moving further, the services which are offered through the targeted interventions is the detection and treatment of the sexually transmitted infections, condom promotion through social marketing, in especially for the high risk groups and the bridge population. We are promoting the use of condoms, and also the social marketing is done. The behavior change communication, wherein we provide the information, education, and we communicate the people to bring in the changes in their behavior which is favoring the health. Creating an enabling environment with the community environment and participation. So, we are creating an environment such that the community's involvement, the environment is such that the community's involvement and participation is seen. Linking of integrated counseling and testing centers. Linkages to the testing and counseling and testing centers. Linkages with the care and support services. We are also providing the care and support service for the HIV positive high risk group. So if a person is HIV positive, if he is HIV positive, we are providing the care and support service for the HIV positive high risk group. Community organization and ownership building. Community organization and ownership building is also included under the services which are offered through the targeted interventions. The specific interventions for the like the drug users, intravenous drug users, specific intervention is performed in this group. Distribution of clean needles and syringes, abscess prevention and management. We are also providing clean needles and syringes, abscess prevention and management. Moving further, opioid substitution therapy, linkage with detoxification, rehabilitation services, specific interventions for MSM or TGs, and then we have provision of lubricants, specific interventions for the target groups. So we see that the target groups and hijras population, provision of project based sexually transmitted infection clinics. So we have the project based sexually transmitted infection detection clinics. Moving further, we have the link worker scheme. The Link Worker Scheme, where it is a community-based outreach service by link worker for the high-risk group, vulnerable group. Objective of this scheme is to provide information on the prevention of HIV, counseling, referral to ICTC, sexually transmitted infection clinic, promotion and distribution of the condoms. So very simple, link worker scheme where the services by link worker, especially for the high risk group, for the vulnerable group. They are providing the community based services, okay, wherein there is promotion and distribution of condoms, and then referral services, HIV testing and counseling, prevention of HIV, and providing information. Management of RTI or reproductive tract infections or sexually transmitting infections include the provision of a RTI or STI in the high risk group population includes the free consultation and treatment for their symptomatic STI or RTI. You can remember just like that, sexually transmitted infection. If they are having the sexually transmitted infection, providing a free consultation and treatment for their symptomatic presentation. The Suraksha clinics, very important. The Suraksha clinics, the NACO has branded this STI or RTI services as the Suraksha clinic. These services for the high risk group, they are providing this free consultation, free services to the people, high risk groups who are contracting with sexually transmitted infections or reproductive tract infections, and such clinics are branded by the NACO as a Suraksha clinic. Syndromatic management based on their signs and symptoms. Pre-packed color-coded kits. We are giving them the pre-packed color-coded kits. We have 7 kits. They are green, gray, white, blue, red, yellow, black. You can see the picture here. NACO is providing this 7 kits, pre-packed color-coded kits. And then we have the blood transfusion service, wherein the professional blood donation is prohibited. Only the licensed blood bank are permitted to operate in the country. So these blood donation, like professional blood donation is prohibited. Only this blood banks have the authority to they have the authority to perform this blood donation, and they have to be licensed and they are operated in the country. Voluntary blood donation is encouraged. Ensure safe collection of the blood, processing, storage, and distribution of the blood and blood products. Testing of every unit of the blood is very mandatory for HIV, hepatitis B virus, hepatitis C virus, malaria, syphilis. Blood safety program, it is renamed as a blood transfusion program. We studied earlier. Further, information, education, and communication. The communication in National AIDS Control Program 4 is directed at what is the aim of this information, education, and communication? It is to increase the knowledge among the general population. This general population, we need to increase the knowledge of these people, especially the youth and the women, on safe sexual behavior. That is the use of condoms, the safe sexual behavior, not to have multiple partners, not to have casual sex partners, and to sustain the behavior change, especially in the high risk group and the bridge populations. We need to sustain behavioral changes in the high risk groups and bridge populations to generate the demand for care, support, and treatment service, to make appropriate changes in the societal norms that reinforce positive attitude, positive belief and practices, so that they can reduce the social stigma and discrimination for the one who is contracted with HIV. So it could be also because of a blood transfusion or the needle usage. So we need to end the social stigma and the false beliefs and practices, so we can reduce the discrimination and bring in the positive attitude in the people and change the societal norms. Okay, So, this is about the information, education, and communication, where we are increasing the knowledge among the general population, bringing in the behavioral changes in the high risk group, generating the demand for the care, support, and treatment, and providing appropriate changes in the society so that we can bring a positive attitude and reduce the discrimination and the stigma. Following, we have Adolescents Education Program. This program runs in secondary and senior secondary schools to build up life skills of adolescents to cope up with the physical and psychological changes which are associated when they are growing up. So this program, it is usually run in secondary or higher secondary, senior secondary schools, that is higher like high schools, higher secondary schools, wherein we are building the life skills of these adolescents, so that if any psychological change or a physical change comes up when they are growing up, that is during the puberty, when they undergo the changes, they should be able to cope up with the changes. So we are improving up, building up the life skills. Provide the education about the AIDS. So right education, right information is the best prevention. By educating and bringing in the behavioral changes in the people, it could be one of the best prevention for the disease. So we need to provide the education about the AIDS in the ages during which they start being prone to such things. Lastly, we have this red ribbon clubs. The red ribbon clubs is to encourage the peer-to-peer messaging on HIV prevention, wherein we encourage the peer to spread this HIV messaging, prevention of HIV messaging, to provide a safe space for the young people to seek their clarifications of their doubts, and also to clear the myths which are surrounding the AIDS and HIV. Okay. The RRCs also promote the voluntary blood donation among the youth. So, this is all about the red ribbon clubs. So, we know the red ribbon clubs, very famous. It is formation in the colleges, it is done so that we encourage the peer to peer. Peer to peer is friend to friend, or like the students will encourage themselves messaging on HIV prevention. They will speak about the HIV prevention so that peer to peer, once a friend, you can open up, you ask doubts clearly, you clear your myths. So peer to peer communication is encouraged so that they can seek clarifications about their doubts, and they can clear their myths which they are having regarding HIV or AIDS. So this was all about the program, National AIDS Control Program. I hope everything is clear. If you have any doubts, put it in the comment section, and if you like the video, hit the like button and subscribe.